This is a controversial area and an area that is really difficult to study just due to the relative rarity of upper tract urothelial carcinoma. But long story short is the authors used the National Cancer Database to get around this rarity and tried to compare patients undergoing a nephroureterectomy either without or with lymph node dissection or lymphadenectomy to look at their overall survival. And long story short, didn't see a difference. The issue is that there's a couple issues with these studies, and it's the authors certainly did their best and did some very sophisticated propensity score matching analysis to try to get over or control for covariates. But one is staging in upper tract urothelial carcinoma is really hard. So they used clinical T2, T3, and T4 patients, but we don't, unlike with bladder, we don't get muscle in the specimen, and we can't do an exam under anesthesia. And so I question the accuracy of those clinical staging to begin with. Next, they defined lymph node, patients receiving a lymph node dissection if they had any lymph nodes mentioned in their pathology specimen. So 54% of these patients had lymph node yields of 1 to 3, which could certainly just be hilar lymph nodes during the nephroureterectomy. So I really question using these retrospective data if you can really tell if there was a definitive lymphadenectomy performed or if these were just lymph nodes that happened to be found with the kidney. In addition, the templates of lymphadenectomy for upper tract urothelial carcinoma are relatively undefined compared to lower tract urothelial carcinoma and very variable. And so trying to understand what a good template is, I think, is something we're still trying to study in the field and something that's impossible to tell from this database. So, interested to see the manuscript come out, but bottom line is this will remain a controversial area, and there will be continued debate about whether lymphadenectomy should be performed in the setting of nephroureterectomy. Notably, AUA and EUA guidelines continue to suggest that high-risk patients undergo a concomitant lymphadenectomy with nephroureterectomy.